Good morning. Welcome to the Thurston County Board of County Commissioners Board Work Session for this Wednesday, March 22nd, 2023. It is 9:03 a.m. My name is Ty Menser, Vice Chair of the Board. Commissioner and Chair Caroline Mejia is present virtually, and Commissioner Edwards is excused today. Public virtual attendants can follow along on the Thurston County YouTube channel. We have an hour slated to address the Thurston County Healthcare System briefing, and we have leadership from our two local hospitals here, and we'll go around and do introductions. But County Manager Miro Chavez is here. We have Emergency Management Director. Did I get that right?
Yes.
Okay. And the
Stan Moon, Chair of the EMS
Council, right. I want to make sure I got that right. Stan Moon from EMS Council. So we're very happy to have all these folks in the room. And we'll just maybe go around the room. And David Bain, start with you.
Okay, I'm David Bain, the Director of Public Health here at Thurston County.
I'm Dr. Bill Krigsman. I'm the Chief Medical Officer at Capital Medical Center.
Good morning, Darren Goss, Chief Executive of Providence Swedish.
Angela Mackey, Communications Director at Providence Swedish.
Okay, great. So, County Manager, why don't you set us up?
I'm really looking forward to this conversation. I know that we have to reschedule this briefing a couple of times. And I think this is in response to the Board of County Commission's interest on how all the system is currently working. And I believe great partnerships have been formed and also a great way to cooperatively resolve some of the issues. Necessarily resolve all, but certainly an attempt to get through the process and see how we can manage the capacity issues that we have in the whole healthcare system. So with that, Ben is going to take the lead on this, and he has a PowerPoint, so let's go ahead and do it.
Perfect. Thank you very much. Perfect. Good afternoon. You'll find that my background as an educator as well, I tend to pace and walk, and I'm really thankful for a sound system that allows me to do that. But some of the slides today are coming from a system-wide approach that, emergency services kind of identified back in January. And so I started, and this has been an ongoing conversation in the hospital sector of how do we break down silos and more effectively treat patients throughout our community. And how do they get access to healthcare? And this broader conversation really needed to spread out into the EMS sector as well. And so this stems from a conversation at EMS Council that I had talking about, look, the patient care that we have in the field really doesn't stop at the hospital door. It's a continuum of care. We have to look at the EMS sector and how we respond to patient care in the field. Then how do we respond to those patients' needs within the hospital from the emergency room all the way up into the ICUs and discharge? And then ultimately, where are they being discharged to? Are they going back home because they're well, or are they being discharged back out into long-term care facilities, nursing homes, or other assisted living, or even healthcare at home, which I'll hear about here later, on getting creative in terms of some of the conversations surrounding telemedicine and those components. So as we walk through this today, we're going to give you a little bit of just a light dusting of statistics, so it kind of frames the conversation that we're talking about in Thurston County. And some of those statistics as we walk through this process will be brought up here as we go through. We've already done introductions, but just to recap, we have both myself, the Emergency Services Director for Thurston County, the Director of Public Health, and both CMO and Chief Executive from Providence and Capital Medical Center present to help answer some of these questions. As we go through, there's just a simple fact. We're growing. This growth in Thurston County, what you'll see in the presentation there, deals with an ongoing growth that's kind of like a moving floor. So as we're looking at what we need for infrastructure, that floor continues to move up. And it's almost like the way I say, and for those of us that remember the original Game Boys, the screen kept moving. You could not go backwards. It kept pushing you just like it does through life. It's kind of like the floor continues to move. As we're consistently making changes, we have to consider that the growth in Thurston County continues to grow at about 1.5% every single year. That translates a little bit more than 1.5%, a 10.1% growth just between 2015 and 2020 alone that we've all felt. That comes into play with the commissioners having new districts because we've grown over 300,000, and all of that comes with infrastructure strains as we grow. As we walk through that process, there's some components of this that I just wanted to call out from a healthcare component. It's not just that our population is growing, but it's that our population is changing. And so that change is something that we have to deal with as a community. You're well familiar with a baby boomer population. And so what you see in this graph, and what's important is not the specific numbers, but the shape. What you notice about the shape of this graph in the 1980s is that you had a boom in population, the very first grayish tan slide. You had a boom in population because of the baby boomer population in the 80s that was centered around basically the 25 and 30-year-old mark. As you notice over the course of time, so as you go up in this slide and back, you'll notice that that bubble passes through the population. But one thing that you do need to be aware of is that the red slide deck in the back is our 2020 population. What you'll notice is in 1980, there was a bubble, what has now become basically straight lines down the side. And those straight lines are a continued need for population support all the way through, and a much greater population at the top, which is in need of healthcare, okay? So we have an aging population as a whole, and that aging population has more and more needs. Now, we've done wonderful things since the 80s in terms of how we look at the length of any given life. So the lifespan has grown almost a decade over the course of that time period. What we see here is almost a decade jump in what the median age was for Thurston County. So we were an average age, or a median age of 29.8 or about 30. We're nearing 40 in 2010, which speaks to an aging population. That aging population has more needs, and we'll talk about that as we go through this process. Any questions on that?
Maybe you can hold the questions to the end.
Oh, okay. So the effects of, this is centered on, what we did is we kind of broke it down in terms of the continuum of care. I'm gonna go through a few slides just to paint the picture for emergency services, and then I'm gonna pass it off to both hospitals and then on to public health as we're looking at the continuum of care. One of the components that we wanted to call out is that we've had about a 62% overall growth over the course of about 11 years in Thurston County's EMS infrastructure. That outpaces, that significantly outpaces the growth that we have in population. And a lot of that is due to age. So the average age in Thurston County for our responses is 60 years old. That speaks to the aging population, the age, and the increased demand on the infrastructure. Additionally, as we go through this deck, we've seen our medic units have an average response time that's been closer to about 12% higher, which is about 463 seconds. And I'm sorry I didn't do the math. I'm not going to do the math on the fly to save you. But the point here is that we've seen a growth in our response time, which is a hazard of having increasing call volumes. Okay, so over the last 2 years, we've seen a pretty significant increase, 14% in 2021. We had another 12% jump this year in medic unit call volume alone. And what you're seeing here is a 12% increase in our response time because of the impacts and the strain placed on the medics throughout the system. Lastly, what I wanted to talk about is one of the components that came up in EMS Council was that we're having increased wait times at the hospital. We can't seem to get our ambulances free because there is no room in the inn. And when we're trying to push on the hospital to take our patients, it's not entirely fair, and what I brought up at EMS Council, to say you must take our patients when you have 60 boarders. Okay, so the conversation that came up in December and January was, what does it look like for a hospital like Providence St. Pete's to have 60 boarders? And those boarders are those individuals that have been evaluated by ER physicians, have then been determined that they need a bed on another floor or continued care, and they don't have a bed and they wait in the ER. To put that into perspective, Providence St. Pete's has 42 beds. 42 beds, 60 patients waiting for a bed. It's a bad math problem, okay? And that's something that we need to be considerate of, that when they don't have room to accept patients, we need to get creative. And some of those initiatives we'll talk about down the road, but looking at that increasing wait time for EMS resources at the hospital is something that impacts our communities. It makes a resource at the hospital that's waiting for a room unavailable to respond for a 911 call in the community. And that's something that we were trying to address and just conceptualize that this is an ongoing problem in terms of the infrastructure, but there's more to that story.
Yeah, thanks, Ben. So good morning, I'm Darren Goss, Chief Executive with Providence, and Appreciate the partnership we've had with Medic One and the multi-care here in the county. We agreed to show 3 slides that we felt were pertinent to the conversation. The first one actually is our ER volume at St. Peter. And so a little different than what Ben has shared with the growth in the community is actually we've seen a small decrease here since 2018. Now it has increased since my arrival, since the pandemic, and we're seeing that continue to move forward. But what as we've dug into this number, that's not been the experience of those in our ER. That's not been the experience at the hospital. We have worked over the last 5 years, as Ben said, you know, as our community is changing, so is how we deliver healthcare. And so as we look at more virtual visits, telehealth, you've seen urgent care, we have express care here in the county, and then also we have immediate care at our primary care practices. Not everyone accessing our emergency room needs to be there. And so you've seen we've done a lot of work in trying to move our patients to a lower cost setting for the right care at the right time. And so we've seen that play out here in emergency room. What's not on this graph though is the acuity. So as we've moved more of our lower acuity patients out of the emergency room, the higher acuity remains. And so on the next slide, we've seen this play out in our length of stay. And so we're shy of about 400 beds within St. Peter. We have on average, I think right now, about 50 patients who need a lower cost setting of care, not the hospital. And we've struggled on discharging, as Ben had talked to, skilled nursing facility, nursing homes, long-term acute care centers, because they also struggle with staffing as well. And so then they stay within the tower, and then that causes our boarding situation, which does impact our ER. And so we continue, this is our number one focus from a length of stay perspective is throughput, to make sure that we do have enough beds here and that we're moving patients as efficiently as we can. And then on the other side, we were looking at our social determinants of health, and so we were looking at our Medicaid, because we know that patient population doesn't have anywhere else to go. And so they do arrive at our emergency rooms. Appreciate multi-care being in the market because they'll see an increase in their Medicaid as we care for the community. What we have noticed is we've had to dramatically change our approach to how we care for this patient population and moving more of our resources out into the community so they're not in our ER. And so even with the growth of the county, we will continue to see a higher volume in both ERs. Now I do believe our ER is sized appropriately. We have to work through our throughput to make sure that then we're accommodating the needs of the Medic One and next steps here. I'll turn it over to Dr. Cruz.
I'm gonna just answer the next question before you go to that opposite side. What are you trying to show? I didn't catch, what's the takeaway from this Medicaid cases by year?
So what we were looking at is there a change in our impact of our ER based on how the economy and other factors have played out in the last 3 years. We haven't seen it dramatically here, but we do think it's changed how we've had to move our resources out in the community to not impact our ER. But at some point, I think this graph will start increasing then as we've tried our best to move most of our resources that we can out into the community.
Thank you. So I'm Bill Krigsman. I'm the Chief Medical Officer at Capitol. I've lived in the community now for 25 years. And so even though multi-care is new to Capitol, our hospital president has been here for many years. I've been here, like I said, for 25 years. We really feel like this is where we live and work. And so I appreciate that. I think the things that our points are similar to what Darren said. I think we look at our ED visits per year. They've been increasing consistent, with the exception of 2020, which was the start of COVID and sort of everything shutting down. And so we've seen consistent increases in our ED volume. What that does is put pressure on the rest of the hospital and results in longer lengths of stay because we're the same number of beds but more patients putting demands on them. And at the same time, then we also have discharge problems when we have a difficulty with getting a patient out to a skilled nursing facility, an adult family home, all sorts of different settings. And we've got the Medicaid numbers that are also just as, for me, a reflection of the community. We take everybody who comes into the hospital, and when I look at that, what I see is this is another part of the piece of finding a place for our patients to go to rehab after hospitalization. That it's difficult, and especially with COVID, it's become, it's added another layer of complexity that we hadn't predicted. And so in my mind, there's essentially a conveyor belt of people starting from good health through having some acute illness and hospitalization and rehab and back to their prior state. And anytime you get a bottleneck or a slowdown along, it just cascades and backs up to everything prior to that. And if the last step is rehab, and that's where our bottleneck is, everything else feels it, and we feel it. And it's not just Olympia. This is a statewide problem. I would say probably nationwide, but certainly in the States, we hear about it all the time. And I'm really happy because Providence and Capital, we collaborate on a number of things. We really see this as a community problem, not an organizational problem. And so having the opportunity to talk with you today is wonderful because we would love to collaborate and see if we can solve some of these issues together.
All right. Like Ringo Starr after the Beatles here. So public health's role in this, I would say, is relatively small, but it's still critical. I want to note this. Actually, Bill did a great job of talking about these pressure points. And one of the pressure points in the system is our long-term care facilities. It's hard to see maybe on this chart, but the outbreaks in our congregate settings are mostly happening in long-term care. So we have some correctional facilities and congregate housing, but it's really, I'd say 80% of it is long-term care. This year, we've seen a pretty significant decrease in the number of outbreaks we're seeing in facilities, which is what you would expect after all the interventions we've been doing. But I want to note that from 2021 to 2022, we basically tripled the number of outbreaks. So last year, you saw just an intense number of outbreaks in these facilities, which again creates backlog throughout the system. I also wanted to note there, it says outbreaks. To be clear, an outbreak is basically more than one case. So that definition and that threshold is pretty low when we're talking about what sort of constitutes an outbreak. I'm going to transition to the next slide, actually. What we're trying to do in public health is to make sure that we're not contributing to the bottleneck there. I think public health generally and our role across the system, both in healthcare and environmental health as well, we're trying to balance public safety with efficiency, right? Ultimately, we don't want folks to be in danger of getting COVID or other infectious diseases. We also don't want the system to sort of shut down. So as we've moved forward throughout this COVID process, working with the State Department of Health, we've been able to kind of move the needle a little bit differently in how we handle outbreaks. One of the things that we really are appreciative of DOH in doing is removing our quarantine requirements. So that frees up the facility. One of the other things that we've done at the county level has really shifted that outbreak management from facility level, where the whole facility has to basically shut down, to looking at units or wings. So you could still function as a long-term care facility without having to shut the whole thing down. The other thing is us really working hand in hand with these facilities and making sure they've got enhanced mitigation measures so that they're able to sort of stop spread before it gets too out of control. So again, our role in this part of the system is to make sure that we're doing our part to release that bottleneck where we can and making sure we're supporting these facilities in their mitigation measures.
All right, some of the initiatives that I wanted to bring up. So we listed off a whole series of problems and concerns. And some of those components we need to address when we're looking at it at a holistic approach on how we're changing and building and growing the healthcare system to adapt to where it currently is today. Because it needs to be adaptable in order to serve the residents of Thurston County efficiently. Some of those components that the emergency services has started to implement are, we have a countywide dashboard that looks at hospital, basically EMS transports into any given hospital. This is accessible in an open platform. You can go to dashboard.medic.one. Anybody in the county, anybody anywhere can look at this. And one thing that it helps to do is not only empower our providers to make decisions in order to help level load to ERs in the hospitals, to be able to pick the most appropriate destination based on volume. When you're looking at the average turnaround time for these ambulances to be able to be admitted into the hospital, these patients to be admitted into the hospital from those transport decisions, it helps to spread out and make decisions at the provider level. But then more importantly, everything about medicine is really about helping to empower the patient. And so if you can provide them the information as to each of these hospitals can equally treat your ailment, if that is the case, this is something that we can present to the patient and say, hey, would you be willing to go to Capital Medical Center or Providence St. Pete's if one side is getting lopsided and this is live? This is live data to help level load the entire system so it doesn't get strained. Another component that this dashboard does is it actually incorporates diversion status for the hospitals. So if a hospital has to go on diversion, there was a very poor way of messaging to an entire EMS community. And so they'd still, even if they went on diversion, they were calling us going, well, why do they keep showing up? They keep showing up at our door, they keep calling. And there wasn't a very clean way to do this. What this dashboard does is actually message out to our providers to be able to say, hey, this facility is unavailable because maybe they're shutting down power to help do infrastructure changes, and they're gonna power back up in a couple hours. This is highly beneficial to the system as a whole, and looks at our community and our region because it ties in Centralia as well. Many of the residents in South County tend to be transported to Centralia, and we have to incorporate them into our catchment area. And that's why when you look at this dashboard, you look at Providence St. Pete's Capital Medical Center and Providence Centralia, as we're looking to level load throughout the system. Additionally, we can keep an eye on any other locations that medic units or aid units or anybody in the system is transporting, whether that be Madigan for our veterans, which I will say about 5% of our transports go to Madigan because we have roughly 30,000 veterans in the community. And then we also have a handful that need to be transported to regional hospitals due to advanced trauma, whether that's Harborview or TG, or whether that's specific thrombectomy services that are offered in Pierce County. That is well under 1% of those that are transported out of county, and it's a pride of ours that since 2017, we've worked heavily to make sure that 99% of all of our transports are held within this community. Because it's better for patients to be treated closer to their homes. It's been proven time and time again that access to family improves patient outcomes. And not having to have family commute up and down the I-5 corridor is something we strive, and we've worked well together. We did a white paper on this if you want any more details on that, but that's in front of you and I can pass this down. This is a component that's been picked up at the state level, and King County is currently looking at trying to implement this with their hospitals as well, to try to look at what it looks like to track these facilities. Additionally, Providence St. Pete's and Medic One went into a partnership. We trialed this, piloted it, it hit the news. I would say in August of 2021, we had a brief conversation about the entryway project. Basically, this is putting 2 EMTs in the entryway of St. Pete's that fits 4 beds. What we were trying to achieve was releasing those medic units. When we talk about turnaround time, that's the time that it takes for an ambulance or a medic unit to offload to the hospital. So they're sitting, you'll see outside the hospital, you'll see a number of units maybe sitting outside the hospital waiting for a bed, just because they're full. They have no room to be able to take those patients in. With that, what we have done is work with Providence St. Pete's to put 2 EMTs in that entryway, where we can then turn back out up to 4 more ambulances out into the system. This was almost a 50% return on investment when you're thinking about the 8 ambulances that might be stacked up, or the ones that you're looking on the dashboard, you're seeing a whole series of ambulances that are either waiting and what their wait times are. This helped us to rapidly get those ambulances back out to their communities. And this turned out, we implemented this full-fledged January and February. We had a return of investment of 130 hours of ambulance time that was turned back out in the community by this initiative in order to get those units back out. And so in terms of a pilot study and proof of concept, you took 2 EMTs, got 4 ambulances back. That's an excellent return on investment. In terms of math, that's great. You take the staffing of 1 ambulance and you get 4 back. That's incredible. And so those are a couple of the initiatives that we're doing to help ease some of the strain both at the hospital and work cooperatively instead of in silos, because that's really what we're looking to do.
What is the graphic means?
Oh, yeah, absolutely. So this is the setup. This is just to show you the setup. This is the 4 beds. The 4 beds that are in the entryway. You see the ambulance bay. Those 2 EMTs staff this entryway. And so those 4 beds are what the EMT is staffing before they enter the hospital. And so this was just a graphic to illustrate that this is 4 beds that are staffed by EMTs in the community.
And then we appreciate the partnership there about getting the ambulances back out. The other thing that, one of the pilots that we've been working on now for over a year is expanding the hospital walls, but more virtually. And so we've launched a program that's starting to become more available nationally. It's called Hospital at Home. And so we have the technology today to have someone seen, and so pneumonia may not need all of the resources within the hospital, but still need a tremendous amount of hospital care. If they meet certain criteria close to the hospital, have Wi-Fi needs, and then also have supporting spouses or other family members to care for them, we can actually have them admitted to home and then send resources out there for their care during an inpatient setting. So we've had about 250 patients go through that, and it's been wildly successful, and we'll continue to explore and mature in the space as we learn more about how to do this. So when you think about the cost per square foot of a hospital, it is one of the most expensive facilities here within the county. And so if we can expand our walls, whether it's releasing, creating more space in our ER or sending more patients outside of our footprint, that's how we can absorb more capacity and really leverage the technology to the best we can.
I didn't know if you wanted, Bill, if you wanted to talk a little bit about the expansion of the standalone ED for facilities?
I love to brag.
Yeah.
So, yeah, so this is one of the things that, and, you know, it's been the Olympian. We've seen that the demand on the EDs is high, and it's probably not gonna drop. There is, when we look at the things we can do, immediate care, urgent cares, those kind of things, they're gonna help. But the population growth is pretty significant. So one of the things that we've done, and we're happy with, is our off-campus emergency department, which is gonna be opening up in December. I think I heard December 15th of this year. And really what that does is it just adds emergency department beds to our community. It has, in addition to 10 beds, it has a CAT scanner, ultrasound. It has the same medications available. It's got many of the same laboratory studies that are available. And so when we've done this in other communities, we found that typically about 96% of people who go to these EDs will go home. And so the demand it puts on the hospitals is about 3 to 4% of the visitors to these EDs. We see it as just a way to expand our capacity to care for patients. And at the same time, know that it's just one segment, that we've got to build up all of the different pieces in order to really provide care. And so I see this as a creative solution, and you know, hopefully helps get our ambulances and our medic units back in service, and really gets patients care closer to home. So yeah, this is a fun project.
Can I ask a really quick question about that? Is it gonna be a 24-hour emergency center?
This is actually licensed under our hospital, and so in terms of licensure, services, it's an extension of our hospital that's just physically separated. And so anything that you would expect in our hospital emergency department, you should expect in this one. One of the things that we're doing though that's an advance for this one, we're actually staffing it with a pediatric emergency medicine physician for the times of the day that are most heavily used by kids. And so we have one of the Mary Bridge emergency medicine physicians coming down 7 days a week. The hours will be, don't quote me on this, but roughly noon to midnight. And so that's an expansion. We don't have that in our current ED. So we're looking forward to it.
So in conclusion, before we open it up to questions, I just wanted to say quickly, I really appreciate the attendance of everybody, key pillars in the community in terms of what it looks like to talk about the continuum of care. In terms of being available today, I appreciate all of their support, and we'd love to answer any questions that you have regarding any of the presentation slides that we brought up.
Thank you. Questions, Commissioner Mensah?
So one thing that, Ben, when you were, or actually, maybe it was David, talking about long-term care, and, you know, that's a part of the system that can create a bottleneck, just like any other part of the system. So I had a meeting with a group of community members that are trying to run like small adult long-term care homes, and they were going through the economics of what, like the rates that are paid by the state. And they're like, I'm not an accountant or anything, but they made a pretty compelling case to me that it's not possible to run the facility based on what the state reimburses for the, you know, the Medicaid patients, I think. So they were basically coming with a desperate plea, like, we're gonna be closed. They were a kind of a consortium of these groups that were trying to work together and share ideas and stuff. And they were like, we're gonna close. I don't think that you, Thurston County, you know, leaders wanna see that because of what we've just explained here. So does that sound consistent with what you guys know? And if so, what do we do? What can we work on a bill to, or you know, lobby our legislators to increase those pay rates so that those facilities can operate at a reasonable profit to stay in business and therefore not create this extra unnecessary bottleneck?
Yes, if that's the answer to the question. Yeah, there was a blitz yesterday that came out discussing Medicaid rates with respect to hospital finances. Hospitals across the state, and I don't have the numbers memorized, but have lost a dramatic amount of money in the last 2 years. Largely, I would say, related to Medicaid. We take care of a lot of patients in Medicaid, and the pay rates are very low. I would suggest that adult family homes and skilled nursing facilities are dealing with exactly the same problem. And so I think we all share that. Medicaid rates haven't risen in
20 years.
20 years. I thought
Yeah,
so.
that's what they were showing.
Afraid to say that out loud.
All these other stats we have about this is growing, that's growing, this is inflation, that's inflation, and these rates are operating 20 years in the past.
Right.
And so those patients today then are in the hospital, and we struggle with the same billing component. There is a state bill that is being discussed as we speak, and so we're very supportive of a change in the rates there.
So that is currently being debated in the legislature.
There's a lot of discussion about that, and I think that by itself would improve many of these steps, because if we can get better either growth in the skilled nursing facility and adult family home organizations, then we can decompress the hospitals, and then we can decompress the emergency departments, and then we don't have the ambulances waiting. It's probably the single biggest problem we have from a hospital standpoint as far as getting patients discharged. Length of stay is a huge problem. We don't want people in the hospitals. It doesn't benefit us for a person to stay an extra day because our revenues are the same, but our expenses go up. And most importantly, the patients suffer more the longer they're in the hospital. Risks of infections, of pressure injuries, just falls, things that happen. And so it benefits everybody to keep this flow happening.
I think there's three things that, to your question. One is the payer rates for patients moving into those lower costs that are setting. Second is the staffing to make sure, so we're very supportive of making sure they have the staff so we can discharge patients. They struggle as the hospitals do too. And then David, you really talked about a key thing that has changed is how the county has looked at outbreaks. And so when a skilled nursing facility would have an outbreak, the whole entire facility would shut down by taking new patients. And that is a dramatic impact to the hospital. So I think the way the county has restructured and relooked at that using evidence-based data to say we only need to now close a portion, not the entire. hospitals can still admit to those centers, and that really does help throughput. So we have seen a dramatic improvement in that space.
I would say, just to build off that just a little bit, Medicaid spans the entire continuum. And so a direct impact actually to both the multi-care system and the EMS system was that Falk Ambulance, one of the largest providers in the US, actually pulled out of the entire region, who was the interfacility provider for multi-care. All of those contracts up and down the Sound now then fell to those services that were left. A large impact to that was ultimately a payer mix. When you're looking at a payer mix, you're trying to make up private, Medicare, Medicaid. And Medicaid is the government, and this is for better or worse, it's their way of trying to fix costs or fix what they're gonna pay out in terms of what it costs, and it hasn't changed in 20 years. And so as you have a higher and higher proportion of Medicaid in your payer mix, you end up having to come up with ways to make up those deficits in a budget when you're balancing your budget. And so that becomes complicated. Falk Ambulance ended up pulling out of the region because it was untenable to be able to stay. And that's something where you're also seeing services reduce, ambulance services reduce their services. AMR just pulled back as well from a region. And so we're making sure we're working with our private partners, our private ambulance partners, to make sure that anything that we can do to help support them and keep them in business, we're doing. And so that's another component of not only how do we get them into the hospital from an ambulance standpoint, but it's also the conversation of, do we have an interfacility transport unit, which the hospitals struggle with at times. It could be up to 24 hours, maybe more, to be able to transport a patient out of the facility in an ambulance and transport them back out. There's this misconception that private ambulances, that those taking them in through the 911 system and those taking them out of the hospital in what we call an interfacility system are different ambulances. They're all from the same pool. And so both the 911 resources for transport services and interfacility transport services are trying to both take people in and get them out with the same resource pool. And so that's a pretty significant impact when you're looking at patient movement throughout the system.
Well, thank you for being here today and giving this presentation. Ben, you started out talking about just the different generations and how that really has had a huge impact to our system, which I'm in total agreement with. And I'm wondering, right, as we move through these different generations, and the different generations have different ways, and Darren, you mentioned this at the Chamber Forum, have different ways of receiving care. And so as we're building this new infrastructures, right, is that something that the hospitals are having in mind as we move through all these different generations? There's just the different ways of, or are we building this infrastructure to address the boom now, and then we're gonna be left with just all this infrastructure that's not gonna really have any, not use, but, it's not gonna have the demand that maybe at one point it did.
I think it's a great question. We believe it's really gonna be more telehealth and virtual care for a majority of the care delivered. Recognizing that hospitals will always have a portion of that you have to come in for a higher acuity. But I think we'll see a tremendous growth in the technology and then the adoption of our patients. Younger is far more willing to have that type of care and actually prefer that type of care than some of our older generation patients.
Yeah, I think there's the growth, so there's a couple dynamics that are overlapping. One is the age in each generation, the size of population in each generation. But then there's also the local issues of Olympia and Thurston County and the region, because when I think about our provision of healthcare, it's not Olympia or Thurston County, it's actually the greater region. We count 5 counties as seeking care from our hospitals. And so therefore, we're looking at not just more than 300,000 people, we're actually looking at supporting 500,000 people in terms of our healthcare system. The growth there is important. I think there's also, when we look at some of our metrics, that we are trying not to grow the hospital in terms of, we want to take care of people at home, hospital at home, super service, things like that. At the same time, we see that the people we are admitting to the hospital are sicker. Because if we can get some people taken care of at home, because of these other pressures, what we're finding is that the acuity goes up. And so our hospital may not grow, but may have sicker people 10 years from now. And so we might have a bigger ICU. And so the look will be different, but yeah, I don't see hospitals going away, unfortunately.
And I don't see that either, you know, I think they're just a main component of the care. Kind of as a follow-up to that, right, as, you know, multi-care is building kind of smaller emergency departments, is that kind of one of the ways to kind of solve maybe the boom that's happening right now? Is it gonna be maybe smaller emergency departments, kind of more spread out throughout the area? You mentioned 5 regions, right? 5 different regions. Is it just gonna be more spread out instead of building, you know, a huge hospital at every location, just maybe more?
Great question. I don't have an answer for you. We don't have immediate plans to do more of them. It could happen. I would say though, it's an alternative way of providing care. The fact that 96% of the people who visit these off-campus EDs go home, they don't need to get admitted, is actually for me a good thing, because it says, well, maybe we don't need a new hospital. We just need, in this case, needed more emergency department beds. At the same time, I'm very aware that an emergency department is expensive. And if I look at really where people can get get quality care at an appropriate cost, the emergency department is not the way to do that. The way to do that is really probably with primary care, or maybe urgent care, or telehealth, virtual visits, totally cool. My 27-year-old son loves them. But I'm not of this generation, so I may not be quite as adept. But I do see lots of ways that we can decompress our healthcare system by being smart, creative, and willing to try these different things.
It's amazing how so much of what you guys are describing is exactly what we're trying to manage in our jail. You know, we have this physical, we don't want to create more jail space. We've been getting people out so that the acuity level of the people in, you know, it's a higher level offender, more mental health. So we need new resources within the jail. We're using care at home, like diversion programs and electronic home monitoring. I mean, it's like, it's very exactly analogous, like challenge. So it's interesting. So what I'm wondering is how, we could do the whole thing, but I mean, the Board of Health should see this information, and maybe David and Ben could do an abbreviated, we could either send a video of this, if it's homework to the Board of Health, or we could have an abbreviated version of it to the Board of Health.
That's a great idea.
And the Board of Health may be a little late, but I'd like to see the Board of Health sign a letter to the legislators saying, you know, we need to increase I'm like thinking about that Medicaid issue, funding issue, if there's a direct way to help the system, you know, I mean, money doesn't grow on trees, but this is a super important, you know, element to everyone in the community. And you get to a point where you pinch and you save and everything, but I mean, come on, 20 years of, you know, the economics just aren't working for the system. So I don't know. The Board of Health would have to debate that point, but it'd be something for them to think about.
Yeah, I think it's probably actual presentation, not necessarily to this length. And I will welcome you both, the 3 of you, to come and meet the
Invite you
Board
to
of
be on the
Health.
Zoom or something if you
I think the Board of Health really will appreciate your perspective, hearing directly from you. So I think we need to work on something like that with the Board of Health.
Can I ask for a follow-up for this? I mean, just as you know, if we're gonna have the Board of Health, I would like to see the data of what is impacting our emergency department. Is it a certain demographic? Is it a certain age? Is it mental health? Like, you know, patients who are having a crisis that are coming in, you know, is it homeless populations? Is it, what is just the different demographics of people going through the emergency system that are creating just this different impact? I had, I guess it's not really an honor, but I stayed overnight at Providence, with a family member, and I was very surprised to see that, it was definitely a certain age demographic that was coming in. It was very different from what I thought, right? I heard, a lot that our homeless population was impacting our emergency departments, but what I was seeing coming in through the ambulances were people who were 65 and older, right? Who were having different strokes. And so it was just really interesting for me to see, just being like, oh, okay, like that impact is quite different than what I thought or what I'd heard. And it was kind of very eye-opening. So I think it would be good if there's some data on that to kind of share on kind of what really is impacting. You obviously cannot send a stroke patient home and be like, it's not something, and you have to have the staffing there. So having that, I think, would be very helpful.
Commissioner Mejia, you've kind of talked about it. I mean, there's so many variables that we're trying to predict. We've got a growing county population, the aging population, those needs are different. We're moving into more telehealth and trying new things to expand the footprint. The type of patient is changing. We're seeing a lot more behavioral health, opioid addiction and other changes that are very different than 5, even 10 years ago. And then as we think through about the services within a hospital, that has changed within about 10, 20 years. In the old days, you get a hip or knee and you had to stay several days. Now those are done in an ambulatory setting. So as we're trying to predict what resources are needed, there's just a lot of variables that we're trying to weigh in and do our best to try to predict how to care for the county. But there's a lot of changes here in the last 5 years.
I think there's also, so kudos on being a secret shopper. That's pretty cool. I think there's another thing that's an easy thing to say that people try. COVID is actually not really a big issue. We always have COVID patients in the hospital, but we are in a post-COVID world in terms of healthcare, meaning it's an issue, but it's as much an issue as maybe influenza might be. Maybe it's more, but it's not the reason why we're filled. But it does have a residual effect that we have so many members of the healthcare workforce who have retired or exited careers early because of COVID and during this COVID, that we're now having staffing problems sort of lagging behind the bubble of actually COVID infections. And so when, at least for Capital, when we look at our census, it's sort of the usual things that we see. It's pneumonias, it's infections, it's surgeries, it's not our ICUs being filled with people in isolation from COVID.
Going back on a few minutes, and over the last couple of years, we've heard the term the hospitals are operating on an overflow. And an overflow affects obviously the medic units. They have to transport somewhere else. So and maybe delay on the care that some individuals may need. Do you care by sharing how that decision-making process of an overflow works from your perspective?
Sure, I think they look different at the two hospitals. Capital is a significantly smaller hospital. And so for us, when we are over capacity, so we measure our capacity by our workforce. And we expect nurses to be able to take care of a certain number of patients. And we have a certain number of beds. And we look at this formula, and we have been at 100% of our capacity or higher for most of the last 3 years. And so we have, through the public health emergency, been able to take certain steps to be able to take care of more patients. The principal way, though, has been hiring more nurses, and they're travel nurses, and they are super expensive. And that is and so we feel the need to take care of everybody who comes in through our emergency department or comes in through their doctor's office or a primary care provider. That's part of the reason why this issue with Medicaid has come up. It's expensive. We don't have as many borders in the ED as Providence does. We felt it in other ways. Whenever we do that though, I'm aware that that is a safety risk for our patients. Whenever we ask nurses to take care of more patients than they should be doing, that's a risk. We've got to do it. We've got to take care of our community. It's really hard right now.
Yeah, for us, it is a little bit of a different situation. We can't say no to ambulances or patients walking in our ER, nor should we. And so as we do an assessment, and if they do need hospital care or care within our footprint, we have to find space. And so that's where we look at alternative care sites, boarding and other areas. And so that's why we are operating on an emergency waiver to expand the hospital footprint as we work through this. Yeah.
I'm gonna just build a little bit. I find a lot of, when you look at that population distribution, there's also some components that have come up in terms of staffing. It really lays out the simple truths on what we have in our community to treat. And so we see a much greater population at the top, and we focused on that we have a population, an increasing population of those over 60 in this community that need services. But what's also important, when you see the red sections of the population distribution, it curves in once you clear the millennials at 40 years old. So those that are bright red on that graph, you start to see a V shape that's coming in. For the population in the United States and for Washington State, if it's not straight down on that population graph, that says that we're stable, we're replacing ourselves. As we slope in, we're not quite replacing ourselves, which starts to speak to staffing, which starts to speak to efficiencies, which starts to speak to telemedicine and everything else, that we don't have the people to continue operating the way we always have, because the population is not replacing itself anymore. And so we have to get more creative, and that's more or less a simple truth, that's where we're at. And so that graph says a lot about the community and how we treat it.
One last question. Masking requirements are ending in a couple of weeks for all of you. Is that you considering to continue with that chart without putting you on the spot?
It's a great question.
We haven't even talked about it yet. I don't think.
Last couple of days, I've
Thanks,
had a
Romero.
bunch of discussions. So multi-care as a group, for right now, hasn't changed. I would expect that we will continue to mask in all clinical areas, because when COVID is added to any other illness, it magnifies the threat to the patient. So I would there may be changes in non-clinical areas at some point, but I think masks in hospitals and probably in clinics will continue for a long time. It also reduces influenza, it reduces RSV, it reduces all of those sorts of things. It's uncomfortable and unpleasant. It might be the right thing to do.
Yeah, not always positive with our staff, but hospitals across Washington, I think, will continue to mask here in clinical settings. But our non-clinical, we will be making a change. So conference rooms and other areas, we will be aligning.
No, I appreciate that perspective, but at least from my personal point of view, because masking requirements cannot be done administratively. I think it has to be based on the need and the care. So I appreciate that perspective.
And probably the same as you, we're also basing on the data out there. We're looking at it's not community prevalence, but it's sort of, we have ways to measure COVID. And Thurston County is still, there's enough COVID out there that we feel like we need to be careful.
Thank you. Thank you again for coming and giving us this presentation, and hopefully we'll be able to see you at the Board of Health. That was very exciting. With that, we are adjourned.
Thank you. Thank you. That was great.